prioritized. I think we are planning to move back into meeting twice a month, just because things are starting to heat up. And so I think we'll probably see a few more meetings coming up being scheduled. And October 13th, we have unhoused populations communication approaches to that group, which should be an interesting discussion. So that more or less gives you an idea of what we've been talking about. At this point, I am available to answer any questions.
Thank you, Lavinia, for the presentation. Are there any questions from board members? Great. Well, I think between our two speakers, we covered this topic well, and to Lavinia and the other people on the work group, just thank you for your time and efforts, and it's I imagine your input on and feedback on especially the toolkit and stuff is invaluable. So so glad that you guys are taking on advising on the sequencing, and appreciate all the investment and efforts. Hope it makes this fairly difficult, very intense process better and more effective. Thank you so much for joining us today. All right, last call for questions. Okay, we will move on to our next agenda item, which is OHA's Government Relations Team and members from OHA's Office of Health Policy team going to join us to preview OHA concept briefs for the 2023 legislative session. And we will get a summary on the recently passed Federal Reduction Inflation Act. And we'll start with Jeff Scroggin and the OHA Government Relations Team presentation. Nice to see you, Jeff. Welcome.
Hi, Vice Chair. Nice to see you all. Hello, policy board members. My name is Jeff Scroggin. I use he, him pronouns. I'm the Interim Director for Government Relations for the Health Authority. I have brown hair, a white face, big brown beard, and a blue shirt on. And we have a presentation for you today regarding OHA's legislative agenda, specifically legislative concepts. I'll flag that this does not include our policy option packages, which are our resource and funding asks, but we look forward to briefing the board further on those next month or whenever is convenient for the board. Can we go to the next slide? Matthew, are you going to facilitate?
Oh, am I?
You don't have to.
I can't. I take over. I just got back.
Okay. So our agenda today, a little bit, so you can see meet the team. You already heard from Matthew briefly. We'll give a little bit of a legislative overview, and then we'll talk about some specific bills, and then we'll have all of the bills, and then we'll have a little bit of time for Q&A. Next slide, please. This is our team. I'm the interim director, as I mentioned. My name is Jeff Scroggin. We have Colleen Benson, who's with us today. Colleen covers behavioral health and COVID-19. Cynthia is also on the team. She heads up our public health, equity and inclusion division and tribes. Cynthia, there you are. I see you. Tristan is also on the team. Tristan is our behavioral health guru and manages the behavioral health portfolio, which includes the Oregon State Hospital. Tristan, are you with us this morning?
Yes, I am.
Great. And then we already heard a little bit from Matthew. Matthew does a lot of communications for us as well as budget assistance. Mary Beth, are you with us?
Yes, I am.
There she is. Mary Beth provides project management support and executive support to the team. She also does some policy work. And then last, Phil. I think he's here.
I am here.
I knew you were here. Phil has the Health Policy and Analytics Division portfolio, as well as the Health Systems Division and Medicaid portfolio. I think I'm actually, if it's okay, going to have each person kind of give a little bit of flavor about what's in their work besides just putting these kind of buckets up here. You can see their phone numbers and emails. So if you're listening in and have a question about any of our concepts or work within these specific buckets, feel free to reach out to the person by email or phone, whatever is most convenient. But just spend maybe a couple minutes here hearing from folks about their specific portfolios and some some pieces that might be listed on the screen. Colleen, would you go first?
Hi, I'm Colleen Benson. I'm the newest member on the team. As Jeff said, I work in behavioral health with Tristan Fernandez, and that includes Measure 110, Oregon State Hospital 988 and Aid and Assist. And I'm still learning a lot. So
Thanks, Colleen.
Thank you.
And the slideshow got taken down, so I don't know who's next, but I'm gonna go with Cynthia.
I am next. It's alphabetical by first name, I believe. Hi, everybody. My name is Cynthia Bronger Munoz, and I have public health, which is a large portion of portfolio that I have. It includes reproductive health, and includes anything that's climate related and climate resilience when it has to do with health. Most things touch public health. So when in doubt, go ahead and email me and I can point you in the right direction. I also support the Office of Equity and Inclusion. Equity and inclusion is something we do throughout our agency, but there are some portions of the portfolio that sit in the Office of Equity and Inclusion, including all the real D and SOG data stuff, as well as traditional health workers, our RHECs, things of that nature that are more focused on equity and inclusion. I support that, as well as anything related to tribe. Again, that's everything in our in our agency, but specifically making sure that tribes are included in policy. And when we're looking at legislative concepts, that they're also included in there. And then I also support education and some of the oral health stuff. So when in doubt, I have all kinds of knickknacks. I love it.
Thanks, Cynthia. Tristan, you're up.
Hello, as I kind of got a little bit of an intro from Colleen, I'm Tristan Fernandez. I handle pretty much the entire rest of the behavioral health portfolio, which includes the state hospital, behavioral health where it intersects Medicaid, and all of the various major investments and ongoing lawsuits that OHA is engaged in regarding behavioral health and its transformation from over the last 5 years.
Thanks, Tristan. Mr. Green.
I'm Matthew Green, and I was on vacation until about an hour ago, so I'm coming back up to speed. But I work on a lot of the communication issues for the government relations, essentially translating between things legislative speak, agencies speak, actual public speak, and work on how we communicate our message, how we tell our story at OHA in all of these different agencies, and also focus on budget issues. And again, it's not just about how much money we're asking for, but what is the story behind it and what are we trying to do with that to ultimately make Oregon a better place.
Thanks, Matthew. Mary Beth.
Hi, everyone. I'm Mary Beth Milieu. I am the GR team's executive support, so I deal with all the scheduling and administrative needs, as well as some special projects for the team. And I also do some policy work on NEMT. So if you have any questions, feel free to reach out to me on those topics.
Thanks, Mary Beth. Phil.
Hi, Philip Schmidt, he, him pronouns. Short dark hair, glasses, headphones, and a blue shirt that I'm not sure. And I, as Jeff said, I cover health policy and analytics and Medicaid. I'm sure the board is intimately familiar with a lot of the topics that health policy and analytics handles, but there are some others like PEB and OEB. The Office of Health Information Technology also is in health policy and analytics, and as well as many of the initiatives, as I said, that you all heard so much about. And then obviously Medicaid is a big topic in our agency. You just heard from the interim Medicaid director who I am supporting that effort, the redeterminations effort, along with the 1115 waiver that briefly came up. So that's my portfolio. I'm the second newest member of the team. So
thanks, Phil.
Yeah.
And just quickly for the board, a lot of the board's committees can fall into these portfolios as well. So for example, behavioral health and COVID-19 or behavioral health and the state hospital, the board has a behavioral health committee. Cynthia has the Public Health Advisory Board and the Health Equity Committee in the Office of OEI. Phil has a lot of committees, the Medicaid Advisory Committee, the Marketplace Advisory Committee, PEB and OEB, the board itself. So a lot of the board's OHIT committee work is bundled within this framework for support. Can we go to the next slide? This is kind of a brief slide about what we do. What does it mean in OHA to be on government relations? One of the things we like to tell people is that we work for people. We hold the triple aim, and the elimination of health inequities in Oregon by 2030 is our kind of mission. And specific to GR, we do a lot of work around the impact to people of health and healthcare. So that means before session, really talking with folks about legislative concepts and ideas that are equity focused and community driven. During session, talking about bills with legislators, community and partners, and then after session, supporting the implementation of legislative ideas, concepts, and bills. Matthew mentioned this a little bit, but we've got a bullet here around translating, coordinating, facilitating, and leading. And that's really a lot of what the GR team does. It's a lot of, like Matthew said, I'm going to translate this legislature speak into agency speak, or back and forth, or coordinate, making sure we have the right folks in the room or right expertise on a legislative matter. Let's go to the next slide. This slide is just to give an example of how easy or not easy this work can be. One of the best examples we have is LC is an acronym. We try not to use too many acronyms. LC gets used twice in the building for two different things, legislative concept and legislative council. So even if you know the acronym, it can still be difficult to tell what folks are talking about because there's so much of that agency or legislative speak. And we've kind of shown the difference between legislative council and concept on this slide. A couple other acronyms were thrown up just to help out. Current service level, CSL, is the baseline budget based on previous legislative decisions. Usually it counts for inflationary action. And then policy option package. I mentioned POPs earlier that we wouldn't be talking about them today, but these are budget change requests when the agency requests resources through the legislature to meet its mission or statute. Next slide, please. Some mandated legislative timelines. And these slides show, obviously, Tara sent the link to them and they're available, publicly posted, but this can kind of show how we'll be moving through the legislative timeline. I'll make one note about this. It says September through November, final draft LCs are available. The team is working really hard. I think we're going to start today putting up legislative concepts on our website. We'll also try to include information about the concepts. We'll see if we can include pop narratives as well. No promises, but hoping by today we can get most of our concepts up on our website, along with some information about them. It might struggle into a couple more days, and for sure by the end of the week you should be able to find all of OHA's concepts that we've received back from Legislative Council on our website somewhere. Next slide, please. We get a lot of information from OLIS, the Oregon Legislative Information System. A lot of people think that maybe there's some magic or knowledge behind the curtain insiders have. No, about 50 to 75% of the information comes from this publicly available tool. So really encourage everyone to check it out. You can find who all the legislators are, what their role is, where bills are, what the amendments that are being considered are, when committees are meeting, who's on the committees, what they're hearing, when work sessions are scheduled, when a public hearing is scheduled. And you can also find the staff for those hearings. So if you have a question about how to testify, you can have that opportunity. So really suggest if folks are looking for more information as the legislative process gets started, that OLIS be a key tool. Next slide. We organize our legislative concepts into themes. Building health equity infrastructure and implementing the health equity definition is our priority theme. Building a post-pandemic public health system is a second theme. We all know that we're hopefully coming off COVID-19, but it's still there. And how we move forward as a state is a key legislative proposal and concept priority for the agency. Oregon State Hospital staffing and improving health and safety at the state hospital is a priority. Medicaid and behavioral health system accountability is a priority, making sure that the transformation efforts that we've been engaged on for the last 15 years for both behavioral health and Medicaid are really bearing the fruit. Implementation of the 1115 waiver and health policy improvements are part of our package. And then lastly, public health fees, housekeeping, and mandated bills, for example, when a court tells us to do something or an audit. Next slide, please. We're going to kind of break up the next slides into some bigger picture, what's going on. This isn't going to be all of the concepts. We'll flash up on the screen all the concepts. And as I mentioned, we'll try to have those all up on our website by the end of the week, if not today. But I want to give some space to talk about some specific concepts, priority concepts, and what their impacts might be. We'll go through these slides and have each person talk a little bit about some pieces within their portfolio. And Tristan, you're up first.
Yep. And I'll launch right into it with the placeholders we have for our community groups. As Jeff mentioned, we are really trying to lift up those voices and made a commitment this cycle to set aside legislative concepts for, I got muted, set aside concepts for our community groups and community councils that the host has continued to mute me, so I'll pause. Do you want me to continue?
Why don't you continue, Tristan?
Okay.
Someone's working on it. Sorry about that.
Oh, no worries. So as a part of that, we have the Oregon Consumer Advisory Council and the System of Care Council did take us up on our offer and brought forward legislative or said they wanted to have legislative concepts. The Oregon Consumer Advisory Council has a pretty firm understanding and idea of what they want to do. At this point, they've asked for a feasibility study to create an independent peer licensing board. I would say this would be similar to something like a nurse licensing board or something like that. And its goal is to have something for peers by peers. They really feel that the peer network has outgrown sitting under the traditional health worker designation and are really struggling with that. The System of Care Advisory Council is going into session with a true placeholder. They've discussed various things about modifying their authority, modifying their membership, but at this moment in time, there is no concept fleshed out for the System of Care committee. They are continuing to meet in their subcommittee for legislation and kind of flesh out what they actually want to do. Payer parity and behavioral health crisis. This is directly related to the 988 system, which I think many folks should be familiar with, but as just a quick refresher, the 988 system is an emergency number that can be called for those in behavioral health crisis that is an alternative to a police response. And so this went nationwide. This is happening nationwide. And as part of those growing pains, nationally, we're already starting to see some of those pressure points. And one of those pressure points is with the private health insurance. Private health insurance has already begun denying claims, apparently, and or taking a position that they may not cover certain crisis services. OHA has already reached out to DCBS and has confirmed that at least under the existing parity law, they do not believe they would have the authority to mandate the private sector pay for behavioral health crisis. Therefore, all of this falls to the Medicaid system at this moment in time to pay for. And other states, you'll probably see this happen in every state eventually, but other states like Washington have already passed similar legislation to try and correct this or try and make sure that private insurance does cover for behavioral health crisis services. The last one, Aid and Assist, is one of the major lawsuits that we've sort of talked about a little bit. For those that are unfamiliar, DRO has entered into a consent agreement with OHA regarding stay times at the wait times to get into the state hospital. Aid and Assist are the folks that are meant to be aided and assisted in their defense. And so they go to the state hospital for stabilization. The wait times to get into those programs has ballooned over the past couple of years. It's actually been an ongoing issue for the better part of a decade. And so as part of the agreement, an independent neutral third-party expert was brought in named Dr. Pinels, who has now submitted 2 reports on recommendations on how the state could get into compliance with the federal order around what wait times need to be so that the state is not infringing on the civil rights of folks waiting in jail for treatment. And so that concept is directly trying to implement the items within those 2 reports that are within OHA's jurisdiction and authority to mandate. I'm happy to take questions on them and pause there or turn it back to Jeff. Thank you all.
Great. And Jeff, do you want to do questions after each group? Okay.
Actually, I was wondering if we could, what works best for you? I was going to try and hold questions to the end, but we can take questions after each group. We have time.
I think board members, if you have a burning question, feel free to raise your hand or interrupt at the closing of that slide. Also, if after things percolate, we have a question. After watching all of them, we will definitely have questions at the end as well.
Sounds good. Let's not seeing any questions. We'll move on. Next slide, please. Public health, over to Cynthia.
All right, so I'm going to go ahead and start with our pharmacy flu vaccination for all. So what the goal of this is so families can go to pharmacy and get vaccinated, everyone get vaccinated. So right now, you have to be 7 years or older to be able to get vaccinated at a pharmacy. So many times in our rural communities, especially, a pharmacy is way closer than any kind of health facility. So families have been going to pharmacies to get vaccinated for flu. But if they have a child that's under 7 years old, they can't get vaccinated at that location, and they would have to travel a little bit further or make an appointment at a health facility to be able to get vaccinate that child. So really, the aim of this is so that families can get vaccinated all together with children that are 6 months of age or older, to be able to allow some more access specifically for a flu vaccination. And that's the aim of this LC. The next one is flavored tobacco and synthetic nicotine, basically a ban. And what we're going for is all products for all flavors. We're trying to ban flavors. I know that many times this targets our young people. And when you look at statistics, there's 9 out of 10 folks that are lifelong smokers start before the age of 18. And when you actually move that timeline to the age of 25, basically everyone, very few people start after the age of 25. So really we're trying to have the flavors banned for all products. And also, when we say synthetic nicotine products, we mean e-cigarettes, and that's one of the ones that's the big culprit right now for our young folks. Moving on to the dental pilot program, project program. So this dental pilot project program, which is a mouthful, has been a key in lifting up some project programs for oral health, specifically looking at culturally diverse and linguistically diverse populations. And it's a way of supporting these pilot programs so that they can be viable on their own. So it's been a very successful program when we look at equity, and starting some really great oral health programs for folks that maybe have been marginalized. And really what we're going to do is this program has a sunset that is coming up. We're trying to get rid of the sunset so that we could continue the support of this work, especially in an equity perspective is really important. So we want to make sure that continues. And then finally, our Death with Dignity fix. So for the Death with Dignity Act has a residency requirement. I know it's been around a long time, but we, as part of a settlement, we are going to be removing the residency requirement, or at least trying to, so that anyone can access this medication to be able to end their life and dignity if they are in a certain criteria. So that removes that residency requirement for folks that are being prescribed this, not for any medical provider. They would still have to be licensed in Oregon. Any questions for these 4? All right, I'll mute myself momentarily.
Thanks, Cynthia. Excited about some of these. Let's keep the train moving.
Yeah, next slide, please. Oh, equity legislation. We all have a piece of this, actually. Advancing health equity is our first placeholder piece, first concept. The agency is involved in a serious amount of engagement and wants to have the flexibility to engage on health equity specifically and particularly. As we go forward into session, it's pretty interesting political time right now. So we feel like it's a good idea to have a placeholder out there regarding health equity. So as the conversation moves forward and as we start to figure out who's going to be in what seat, we have the ability to have a concept related to equity if it's needed. I'll turn to Cynthia for the next one.
Awesome. So confidentiality and race, ethnicity, language, and disability, or we call it Real D for short, and sexual orientation and gender identity, or we call it SOGI for short. So confidentiality and Real D and SOGI data collection. So it just clarifies that this information is confidential so that folks' information is protected when they do share their Real D and SOGI data in all aspects. So we want to make sure that folks feel that they can share this and that it's confidential. And we also don't put marginalized communities in a uneasy situation or even sometimes a dangerous situation by sharing this information. We're like, for example, someone that is blind, that lives alone, nobody can publish their name and their disability and the fact that they live alone, and that has happened. So we want to make sure that we protect folks from this data being out in public.
The last bullet on here talks about committee membership, and this one's from Matthew. But before Matthew jumps in, I just want to say that this is specific to compensation and stipends for committees rather than committee makeup, which I think the board has had an interested in previously. Matthew, do you want to give a quick briefing about this one?
Yeah, as I'm sure members of this board know, that OHA is associated with a lot of different advisory board committees, technical advisory boards, and it's been recognized by many, including I believe you, that it is important to have a diverse membership, and in particularly the consumers of many of the health services that are being provided. That is, in many cases, people who are not being paid to be there by some organization. And this bill is aiming to make sure that, excuse me, everybody on some kind of advisory committee associated with OHA is able to receive basic compensation. It's pegged to what legislators receive as per diem daily, as well as compensation or reimbursement, I should say, for expenses associated with travel, it could be childcare and other things, to make sure that the finances, at least as a minimum, are not a barrier. This does not address every issue related to increasing representation, but it's the first step toward that, on at least dealing with the financial issues. And yes, it is intended to include subcommittees of this board. So I see one question.
Sandy, go ahead.
Yeah, I just have a question. Your Real D. So if I'm Native and also I'm, maybe part white, which I am. So how am I going to be determined with both race and ethnicities? Am I going to be, I'm an enrolled member, but then also on my other parents' side, I've got, how do you guys determine that and categorize myself?
Yeah, so this LC specifically doesn't really deal with that. Usually we just ask folks how they, because again, Real D and SOGI are like really personal things. And really people self-identify for the most part. But this just protects this data. So it only protects it so that it's not out in the public. It doesn't really deal with how this is collected. But for the most part, it is self-identification because like you said, especially race, it's a made up construct, right? It's a social construct. So it's really hard to determine people's race. It's more of a self-identify kind of thing. I don't know if that answers the question.
Well, yeah, it does kind of, but if I go to my local hospital, they don't have Native American on any of their information. So I don't know how I'm actually put into the system as a non-white person. I don't know. I'm just asking you as authority, how do you determine that, and how do you work with the local hospitals to make sure that I'm categorized correctly? And then my second question is in regarding to, you know, the implications for Oregon under the HR 5376. Once this act was passed, there's only one. So in Eastern Oregon, there's only one Medicare provider out here. We don't have multiple providers in Eastern Oregon. So it's EOCCO. I mean, it's not EOCCO. It's oh shoot, I can't even think of the name right offhand. It's just, but there's only one provider. And there's no other opportunities. You know, you say that, you know, that Medicare Part D, your pharmaceuticals will not be past $2,000. So I guess you're kind of stuck with what you got out here in Eastern Oregon. You get what you get and you pay what you got to pay for your medications in Eastern Oregon, those, you know, annual out-of-pocket costs. So I guess I was just curious, when this legislation and this bill was passed, what kind of implications are going to affect our elder population, which are the most vulnerable population. So thank you.
Thank you for your question. I see that Leanne has her hand up, and I think she's probably the best person to answer. So I'll be quiet.
Good morning, Leanne Johnson, Director of the Equity and Inclusion Division. She, her, hers, Black woman with hair pulled back on a neutral background wearing glasses. I can answer the question about race, ethnicity, language, disability, sexual orientation, and gender identity, and how we collect those data. So any entity that is using the what we call the RealD SOGI data template can choose multiple demographics. And then when it comes to race, ethnicity, they can choose the primary race or ethnicity. And so that is how the system would identify from the standpoint of the aggregated data. And the whole idea behind the RealD SOGI is to arrive at granular data and also provide the opportunity for that self-identification. Those are the two primary principles. So this is a good question because the primary race ethnicity question does allow very specifically for someone to state where they identify, predominantly where they identify, and then also identify all that they related to their heritage.
And then the second question, I think, was actually around the Inflation Reduction Act, which we're going to follow this briefing with, Sandy. So I think we'll have more time to talk about what that House resolution you mentioned's impacts are. I'm not sure we're going to be able to answer your question. I don't know if Devlin is on the call early, but there you go, Devlin. I think that'll be the first question.
Well, let's. I made a note of that question. I'd love to punt that one until after Devlin and Sarah's presentation, because I think we'll have a more rich, not just for Sandy, but for all of us, it will understand the answer a lot more better, or at least speaking for myself. So let's hold, Sandy, if you don't mind, let's hold on the second question. And Leanne, thank you for jumping in. All right, Jeff, turn it back to you.
Okay, next slide, please. And over to Phil to talk a little bit about some health policy and Medicaid pieces.
Hello again. There's really two placeholders on this slide, both of which you're very familiar with, and then one LC that I'd like to talk a little bit more about. The first is the state-based marketplace, and that's the one that I'd like to talk a little bit more about. Currently, Oregon uses a federal platform for healthcare.gov, so the marketplace that we all know and folks around the state use. That actually is quite limiting to our state in a variety of ways. It's not flexible in key moments, like redeterminations is a great moment to, in those flexibilities and that, or inflexibilities, the way we see it really inhibit our ability to help people move between marketplace and Medicaid, marketplace and private coverage, to sort of move around the system. it also inhibits our ability to have data to figure out where people are coming from and going and that sort of thing. So the proposal within the legislative concept is to move to a state-based marketplace. Many states have these, and over the years, there's now sort of off-the-shelf products that you can use. So, and this is software that would come off the shelf, be customized to Oregon, and enable us to really sort of control our own destiny, if you will. And really, I think, most importantly, allow us to focus on the needs of people living in Oregon, to focus on our 2030 health equity goal, and really make sure people stay covered in the way that suits them best across our various systems, but specifically within the marketplace. Moving to the next bullet, we have a placeholder for the 1115 waiver at the end of this month. We're now in September, hard to believe for me at least. We will be done our negotiations with the federal government around the 1115 waiver, which of course this board is very familiar from repeated conversations. And this placeholder will be the place for the agency to propose changes and in statute that we need in order to implement the agreement that we've landed on with the federal government. And the last bullet, redeterminations, again, you just had a robust update. We actually put this on this slide, not because we need further legislative authority to deal with redeterminations, but because when we're presenting to community or to other interested parties, we want to remind them how important redeterminations is to the agency and to our effort to keep everyone covered that currently has coverage. So we use this as an update on redetermination. So again, you all just got that. So I will pause here in this presentation and turn it back over to Jeff.
Thanks, Phil. Next slide, please. So I promised we'd show the whole list, and here it is. And I also committed to getting these all up individually on our website, which I'm hoping to do today. It may be a couple days before we have them all up. We are still waiting for a few to come back from Legislative Council, so those won't be up there. But we kind of covered some of the ones that we think are priorities or might be of interest to community and the board today, but you can see them all on this slide. And again, they'll all be transparently posted to the website for everyone to see. Next slide. And that's it. Bill has a real hand up.
I couldn't find a way in the Zoom to raise my hand virtually, so it's a great presentation and a very ambitious list. Thanks for sharing all this. I had two questions. Maybe I'll ask them both and then you can take them in whatever order. The slide summarizing the 2023 legislative themes. This looks like an excellent list, but I was struck by, I didn't see anything at least articulated there about other elements of the triple aim, particularly around cost and quality, for example, patient safety. And I wondered if what the thinking was about how to prioritize what would be in those themes. Second, on the following slide, which is around major behavioral health legislation, I totally agree that the state needs to address the serious problem that the state has with access to good quality behavioral health services. Could you just say a little bit more about that second item, which is about payer parity in behavioral health crisis services?
Yes, thank you, Mr. Kramer. I'll take both of these. Tristan or Colleen, feel free to chime in on the behavioral health question. I scooted through the triple aim real quick and didn't articulate it. The triple aim is better care, better health, and lower costs. But it is, our themes are inclusive of all three. They're just not spelled out. And maybe that's because it's a little bit too much inside baseball and we should spell them out. So that's a good note for us. We'll probably do that. I do think all of the elements we talked today have a tie to at least one triple aim element for sure. And then the next question about behavioral health and specifically the legislative concept related to what we're calling pay parity. I think my understanding is this is around crisis services, expanding crisis services, and there being payers for crisis services other than, frankly, the state general fund. if you have insurance, that insurance should cover behavioral health crisis services too. And that's what this concept does, is ensure that if you have insurance through a different mechanism than the state, if you're not on Medicaid, but you have maybe employer-sponsored care, then we want to be clear that pay parity includes behavioral health crisis services. Tristan or Colleen, anything to add?
Nope, that is correct. And yes, my understanding is it would add it to the payer parity bill that we saw in 2021. It was just, like I said, DCBS does not feel confident that the existing payer parity legislation covers crisis services.
I see Ebony has a question too.
Yeah, I had to jump off to jump back on. So if y'all spoke to it, forgive me, but was wondering if maybe in a future meeting, would like to get, OHA's and government relations perspective on the Mossman order, and just kind of the impact and kind of expectations in terms of moving forward around transitions out of the state hospital. And so, and then again too, with kind of future legislative concepts, it'd just be kind of good to understand how that ties into everything. And so that's just one little place where my mind was at.
That sounds right to me. We will definitely be talking about the Mossman order with this board, I suspect. We can even talk about doing that next time, or I can work with Tara to figure out what makes sense. And since you gave me the opportunity, I'm going to make a plug. There's a Zoom event later today at I think around 3:30, where the agency is going to be presenting information on what the Mossman order means. So if you're available and interested in wanting to learn more about what Ebony is talking about, feel free to shoot Tara a message and we can get that invite out to you so you can hear the conversation with OHA later this afternoon about that very thing. Tristan, do you have any cleanup for me?
Nope. Yeah, it is 3:30, and I will just highlight that that direct legislative concept is tied to that aid and assist concept that I spoke about and Dr. Pinel's recommendations. And for awareness, the order that Judge Mossman ordered, or what Judge Mossman ordered, was part of Dr. Pinel's recommendations in both her first and second report. I would just say that he has gone at an expedited timeline from what both the state and county was ready for, or we're expecting, I guess.
Tara, could you put that information in the chat if it's not too difficult, just so people could easily access information for the meeting at 3:30? And then Jessica has a hand up. Yeah, thank you. So my question was about the marketplace. I remember this was there was an attempt to do this under Kitzhaber's governorship, and there was about over $100 million spent on this, and we still didn't get one. What is different about this, and how, what's the plan to prevent that from happening again? I'm a little bit confused about why we would attempt this now, given kind of the challenges that we've had over the last couple of years with implementation of programs.
Thanks, Jessica. I can take this one, and Phil, happy to have any additional thoughts from you or anybody else. We did do a big effort more than a decade ago around the health insurance exchange and the platform. And like you're talking about, Jessica, that didn't go as the state expected or wanted. There was a lot of money spent. And I think there's something to be said for innovating and dreaming big. And we definitely pursued both of those values with the gusto. And since then, we have hitched our wagon to the federal technology. So we have our own state-based marketplace. We don't have our own technology to run it. So we've had our own state-based marketplace since then. That's not a new thing, but having the technology to run it, our own technology, that's what's new under this concept. Every state that has their own state-based marketplace, I think, maybe with the exception of one or two at this point, has their own technology as well. In fact, it's been so long that the technology is easy to procure and not very controversial, because it's been more than a decade since they first started to figure out what should this technology look like. We actually think it's possible we might save money in the long run by using an off-the-shelf vendor to provide a technology solution rather than continuing to use the federal technology. So there's a couple reasons why we think the timing is right to move to state-based technology. We're one of the last states to do it, probably because of a hangover from what you're talking about, what happened a decade ago. But it's really not a controversial move outside of Oregon because other states don't have that history. And I do think that we're hearing that, now's the time and Oregon should be in charge of its own exchange. Phil, did you have anything to add?
The only minor point is that we have built in a timeline that would allow us to both explore this, to have a conversation with folks like you and the legislature, and implement this for the plan year 2027. So there'll be a sufficient runway to look at this technology and make sure it would fit, as well as implement it, and hopefully examine any of the downsides well in advance of inviting regular folks in Oregon to begin using.
That's really helpful, Phil.
Can someone just do like a quick sentence on why? Like, what is the benefit of that? I mean, we already have a system that we're using. Why pump more money and effort and all that into this? What are we getting for that?
I'll take a whack, and then I'll ask Phil to take a whack too. Just first, really quickly, it may cost us less money in the end. So there may be an initial financial investment, but one of the things I want to hammer is that it seems that the technology is no longer controversial and doesn't seem to be costly in the end. But there's a lot of things having our own technology lets us do. And one great example is redeterminations. I think you've been hearing a lot about redeterminations. So we don't have control of our own technology. So we can't use the exchange to have a custom solution that works for Oregon. We can't use the exchange to do anything that's a custom solution for an Oregon, like a special enrollment program or special projects like the COFA program that used to exist. We didn't have that integrated with our technology, and there's no way to integrate any program with our technology to meet Oregon's needs as long as we're using the federal version. Phil, did you have anything to add?
I think I think the key word is flexibility, and aside from what Jeff mentioned, I think that being able to control and access our own data would really be an additional benefit that would allow us to, again, meet people where they are or do warm handoffs between systems in ways that the federal technology really doesn't allow.
We can't access our own data right now?
Not in the ways that we would want to be able to, again, do these warm handoffs to understand what, the unique, I mean, we have access to our PEB and OEB data, we have access to our Medicaid data. We don't have the same ability to really get into the granular details of the marketplace.
Sometimes it's about the timeliness of the data, like what we have, when we have it, what we can do it, how we get it back, how it can be used. All of those things are, frankly, we're at the whim of the federal government.
We've had some conversations about this as it relates to the bridge program as well. And I think just one important aspect of this that I found compelling, because I also have I think there's so many people in Oregon who have a lot of you say state-based marketplace. We have a lot of anxiety from 10 years ago, which is totally reasonable. But one of the things that I found interesting to think about was not from the agency perspective, but from the consumer perspective. So a person going out for looking for that health insurance, being able to go to a single site for one-stop shopping, and through that site, that would be a state-based site, could access either an exchange plan, Medicaid, or many of Oregon's unique plans around COFA population, et cetera, or maybe even someday a bridge plan type plan. So I think from a consumer perspective, there's a lot of advantages to pursuing this as well, so that we don't have to enter our information 10 times or know the exact place to go because one's federal and one's state. Yeah, I mean, it seems like there's definitely some benefits to having that flexibility. I just worry about, again, our ability as a state to execute on and actually implement some of these things. I mean, we still haven't gotten that Measure 110 money out That's really far behind, and you could argue that that was sort of a, maybe simpler to kind of get over that hump than something like this, which is, would be represent a pretty big overhaul of the system and transferring all that data. I mean, it's quite involved, and we already wasted more than $100 million on this the last time. Granted, there's a different situation, but I think the tolerance for wasting more money on something that we can't implement is really not there anymore. Great, thank you, Jessica. Sandy.
Oh, I just want to jump in. I was involved in that quite some time ago. But having your own platform, you're still paying the feds for the system that we're currently utilizing. So when you look at it, the bigger picture, yeah, there was a lot of failures. It was rushed into. There was some information that the tribal organizations were involved in, and it wasn't brought over. But I think in the longer run, and being an ex-marketplace on the advisory group, this is a long time coming. You're still paying feds for the system. So, I guess just depends on, and then plus, I guess, the company that was utilized at that time. So, but there is a lot of more information that can be gathered that's important for the state of Oregon. So, it's got to balance that. And I know it's been brought up at the Marketplace Exchange Advisory Group quite, the 4 years I served on there. So just FYI.
Great, thank you, Sandy. Any other questions? Okay, well, wonderful to meet you, GR team. Thank you for sharing your portfolios with us and for the busy season ahead. And I'm sure we'll see you again and look forward to hearing about how some of these develop. Next, I'm really looking forward to hearing from Devlin Prince and Sarah Bartleman with their summary of the Inflation Reduction Act. I think it'll have a lot of implications for us. So I'm not sure who to turn it over to, Sarah or Devlin, but all right, Devlin, floor is yours.
Yeah, hi everyone. While the slides are coming up, I'm Devlin Prince. I'm with the Office of Health Policy, and I'll just go through the Inflation Reduction Act, kind of a broad overview of it. So next slide. So it was signed by President Biden on August 16th, and some of the provisions will begin in 2023, but they will happen over the next 5 to 10 years. There are 3 kind of big areas of this bill. It's a 730-page bill. We're going to talk about the healthcare provisions as part of it, but there's also a big section on climate and environment and also on financing and taxes. Next slide. So the 2 kind of areas that we'll talk about today and that I'll take you through is there's a huge section to help people who are on Medicare. So Medicare prescription drug policy has a bunch of parts to it, including a price negotiation program, requirements for vaccines, changes to cost sharing, and rebates that drug companies and manufacturers will have to pay. And then a second piece of this is the healthcare marketplace subsidies, which is a continuation of another program. Continue, or next slide. And next slide. So the best way to kind of go through the drug price negotiation program is to talk about the process. The Department of Health and Human Services, for the first time, will be required to negotiate with manufacturers and lower the prices of certain selected drugs. The idea of this is to create a maximum fair price. And some clarification on this bullet point is the maximum fair price is based on a historical price, not necessarily a full ceiling price for whatever that drug is. The Health and Human Services Department will it's in parts. And the first part is they'll take the top 50 spending drugs highest spending drugs on Medicare, and then from there, they'll cut it down to a smaller list of 10 drugs starting in 2026, 2027 has 15 and 15 for 2028, and then 20 more in 2029 and every year after that. So it's kind of uncertain at this time how many drugs will end up on this list of the negotiation price, but this is the beginning. Next slide. So they call them negotiation eligible drugs, and in order to be met with that criteria, they have to be covered under Part B or Part D of Medicare, has a high level of spending, and that level is $200 million or less in the previous, or $200 million or more in the previous year has to have been spent on that drug. They have to have no marketed generic equivalent. So this is really aiming at drugs that stand alone and don't have too much competition. And they also already have to be FDA approved for at least 9 years prior to the implementation. You may also see 7 years, and that's because the list that comes out starts 2 years prior to when the new price will start. Drugs will not qualify if they are orphan drugs. So these are specific drugs that have one rare disease whose only approved use is for that disease. Low spending, as I said, the idea is to really get at those high cost Medicare spending drugs, and then whole blood or plasma. Next slide. So this is the really, I think, really interesting piece of this whole bill is it has some teeth to it. And if manufacturers don't agree to this, one of the big important things is they would have to withdraw their products from Medicare and Medicaid programs. So if they don't want to do this new price, they have to pull all of their products. They also have to pay an excise tax that can go as high as 95% on their total sales for the drug, not just sales within Medicare, total sales. And so it's really putting some teeth, I said, behind this bill. Next slide. So changes to Medicare Part D. The first big piece is that there will be a $2,000 annual cap. All Medicare Part D beneficiaries will have this, and it will start in 2025. There's no cost sharing over the catastrophic limit. So currently people pay 5% over the catastrophic limit. That limit, I believe in this year was around $7,000. And so, and that changes. But moving forward, starting in 2024, Medicare beneficiaries will not have to pay anything over that catastrophic limit. Finally, a reduced cost sharing for insulin products. So it's going to be capped at $35 per month for anybody on Medicare Part D, and they're not going to be subject to any type of deductible. Next slide. Next slide. So two other things is that drug companies will have to pay rebates on prices rising faster than inflation. So this is the inflation part of the Inflation Reduction Act for the healthcare sector. It's going to start with 2021 as a base year, and then it follows the Consumer Price Index or CPI inflation, and any type of additional percentage of the price that is higher than inflation will be paid back into the Medicare Part D, the Supplementary Medical Insurance Trust Fund. There's going to be no cost sharing for adult vaccines under Medicare Part D, which means there are no copays, and as well, something that's really exciting for the rest of the United States is that all states' Medicaid and CHIP programs are now required to cover approved adult vaccines. Prior to this, they were not necessarily required to cover them. They now will, and there may be copays with these, but once again, this is mostly focused on Medicare. Next slide. So I put this in here and you can refer to it later. The biggest thing that I wanted to point out is that the negotiated prices for the drugs really start in 2026. And they're only going to be Part D for the first 2 years. And then they'll add in Part B medications and prescriptions following that. And so the list that will come out that we'll actually see starting in 2023 by fall, I believe September 2023 is when you'll start to really see that initial list of the drugs that could be be impacted by this. Next slide. And the second piece of this is the continuation of the the continuation of the American Rescue Plan Act that started in 2021. There's $64 billion in additional federal subsidies that are going towards the ECA marketplace exchange. So this is really exciting. It will increase subsidy amounts for individuals with household incomes below 400 of the federal poverty level, and extends eligibility for people with household incomes above 400%. No family required to spend more than 8.5% of their household income towards the cost of the benchmark plan. Next slide. And so I'm going to highlight a few Oregon implications. There's many, and I believe the policy brief was shared with you that goes into some more details, but next slide. So one of the biggest pieces of this is 15.2% of people in Oregon are on Medicare, and this will impact all of them, specifically those who are on Medicare Part D. There's also, the potential to mitigate the Oregon's increasing Medicare pharmacy costs. And this is very, very exciting. Next slide. And so just to remind everyone that the Cost Growth Target Advisory Committee will meet on September 9th at 2 p.m. And they'll continue a conversation on value-based payment, compact, and work group. It's going to be a deep dive into pharmacy, which is kind of what we've been talking about. So reviewing additional OHA and DCBS data on pharmacy cost drivers, an overview of state and federal strategies to address pharmacy costs, and prescriptions on Oregon's Prescription Drug Affordability Board, the Prescription Drug Price Program. Next slide. So I know I went through a lot. It's a really big bill. I am here for any questions. There's, as I said, it's like 730 pages. There's a lot of pieces to it. I'm excited. I keep learning more and more about it, but I will take any questions.
Great. Thank you so much, Devlin. Bill, I see your hand up. I'll call on you next. But before we do that, I'd love to make sure that and Jessica, I see you too. Want to make sure that I want to throw out, Sandy had a question a while back around the implications of HR 5376. I think it was around the 2000 cap when there's a single Medicare provider like there's out in Eastern Oregon. But Sandy, do you want to restate your question?
Sure. So, when we look at Medicare providers in Eastern Oregon, and which I represent, there was not a lot of people looking to be CCOs out here for Medicaid. So we only have one provider. Sometimes there's multiple providers within a county or a region. So, and then it kind of limits what type of package you can provide as an elder, and then you're kind of stuck with what you get. So I was just curious with the IRA package, if there's going to be any I guess, diversification out here. I'm not, we're not downtown Portland, we're not metro, we're, rural Eastern Oregon. So that was my question.
Yeah, and there's no direct provisions on diversifying for Medicare providers. However, I do think that controlling for the costs will allow for more providers to also control for their costs. So there are some implications that are not seen, and I can look more into this for you for sure and get back to you.
Great, thank you, Devlin. And Jeff, is your hand up relative to this question? Go ahead.
Yeah, I was listening, Sandy, and I think I'm not sure if we're having a little bit of confusion about Medicare and Medicaid. I know there is one Medicaid provider out in Eastern Oregon, EOCCO, like you mentioned. So we can look at maybe what else we can see about Medicare, and like Devlin said, get back to you.
Thank you. All right, Bill.
Hi, Devlin, a great presentation. Covered a lot of ground in a very succinct and clear way. I appreciate that that summary. Question about the drug price provisions, both price negotiation and the inflation rebates. Understand this will be a real benefit for Medicare recipients in Oregon. I wondered if you had thoughts, or maybe you heard others had thoughts, about concerns that this might actually have an adverse effect on people with commercial coverage, since there's thought that the drug manufacturers may use pricing strategies to increase prices in the commercial market to offset the likely loss of revenue in the Medicare line of business.
Yeah, there has been some talk on that. And then I've heard others talk about, though, how this implication has a general new price set. And so, you know, commercial plans will see a price that Medicare is getting and then could use their negotiation power as well to get closer to that price. There's also, you know, the big impact is that the drugs that are on Medicare and Medicaid are all shared. And so I do think that there's a discussion that there might be increased costs for commercial plans, but the biggest might be the initial cost of new drugs that come onto the plan. And so that is where, you know, commercial pricing could get impacted, as well as other plans for any new drugs.
Great. I know it's a complex area and there are arguments on both sides. I think at a minimum, it's something worth monitoring closely in the state to see what the impact would be on commercial prices. Thanks, Devlin.
Absolutely.
Can I make a really quick response, Kirsten? Yeah, I think, Mr. Kramer, it could go either way, right? It might be that the negotiating actually drives down the cost of drugs everywhere too, because everyone can see negotiated price. So I totally think it's a bit of wait and see. We're going to have to see. I totally think we're going to hear about cost sharing as a result. Regardless, we'll just have to see what the data shows. And I wanted to make a plug for our DCBS friends if they're listening in the Prescription Drug Advisory Board, because I think they might have a piece of monitoring some of what Mr. Kramer was talking about.
Great. I think that will be interesting to watch what happens to prices for different payers. Bill, is that anything else? Okay, great. Jessica, floor is yours. Yeah, I guess my question was pretty similar to Bill's in the fact that, you know, we've got these pharmacy benefit managers involved in that process. And it really makes the drug pricing process convoluted and the implementation of that convoluted, management convoluted. So I guess my question was, how are we even going to, what's the transparency piece? How are we going to be able to tell, you know, if those rebates are actually being, you know, calculated properly? And I think the impact to the private or the, you know, private insurers market could be pretty significant. And we know, I think from other types of programs where you kind of have price pressure on one side, that what they'll do is, because there's not a lot of, I mean, insurance has to cover some of these drugs, or most of these drugs, under even the private insurance plans. And so there's limited negotiation that they can really support. It's just kind of the nature of what we've got right now. You kind of have a system that's half in public, half in private, without really a way to manage costs on the private side. Any comments on what you think that's what's going to happen there, and how to prevent sort of this one-rated pricing?
Yeah, actually, Sarah, do you want to go for that?
Yeah, I can take a stab at this. Hi, Jessica. Thanks.
Hi.
I think one of the reasons that we had that last slide plugging the cost growth target committee meeting on Friday is that we are planning on looking at a deeper dive into some of the various strategies that exist at both the state and the federal level for addressing the very complex world of pharmacy costs and pharmacy prices and ways to control that. And as you say, rebates are incredibly complicated. I think we've seen estimates that rebates can be up to half of the price of the total amount back from Medicaid, and that varies by market. And so there's just so much nuance, and there's a lot of vagueness and uncertainty into where those rebates are applied. Are they applied at the manufacturer? Are the manufacturer rebates, are they applied at the PBM level, at the insurance plan level? Are they patient rebates? Are they provider rebates? I almost said kickbacks, that's not right. But there are just so many different pieces of that thread that, I want to second the shout out to DCBS, because the Prescription Drug Price Transparency Program and the Prescription Drug Affordability Board are both charged with looking at how some of those dollars flow and where the rebates are affected in the system and how we can see that. And so I think we have some policies in place in Oregon that are already starting to monitor that to better understand the impacts. We're also collecting some data in the cost growth target program on the cumulative effect of rebates. And so what's happening with prescription drug prices, net and gross of rebates. So I think we have a lot of this information, and we're just really starting to piece it together to understand the true picture of where this is showing up, and then understand what the potential policy options are and whether those are state, federal, insurance strategies. There are a lot of various entry points into the system to look at this. So I think what I'm trying to say is it's really complicated. We do have some more data on rebates. There's no one easy answer of like rebates are here and you can see them here. And I want to plug the Friday meeting for some more information on all of this.
So one thing that I would encourage you to kind of take a look at, you probably already are, is, that you hear about, and I've actually experienced this, is where you go to fill a prescription, and let's say you lost a bottle of this and you have to pay out of pocket. In some cases, you're out of pocket just buying it can be less expensive than actually putting it through your insurance. So maybe your copay is like $30, and to buy this drug, it's $25 with your pharmacy discount. How do we make sure that this isn't happening? Because that's costing a massive amount of dollars in the system. So take a look at that and see maybe there may be some bumpers you can put around just to make sure that at the very least, if you're putting it through your insurance, it is less expensive for the consumer.
Great flag. And I think everything I said applies. Again, this is a really complex system, and there's a lot of different policy levers that would address that problem as well.
Thank you for taking that on. Yeah, not easy work. And thank you, Tara, for putting some links in the chat to those upcoming conversations. Any other questions from board members? Okay, I have one comment and one question for Devlin and Sarah as appropriate. I guess my comment first is thank you for also putting together the written summary of this act. Really appreciated that. And I wanted to flag that in the overview you had a comment about, and in your slides you also was like, okay, this act covers these three areas, one of these being climate and environment. I really appreciated in the overview of the written summary that you called out how addressing climate and environment concerns does have indirect health impacts. And so I just thank you for doing that. Spot on. And then my question is around this 8.5%. This is around extended eligibility and 8.5% of household income towards the cost of a benchmark plan. Does that mean that 8.5% will be, because of this act, will be the new affordability threshold, so that say I have an employer offering me a plan that takes up 9% of my household income, would I then be eligible to go to an exchange and access some of these tax credits?
Yeah, so the 8.5% originally prior to 2021, there were no subsidies for the marketplace for anybody making over 400%. Now there's the contribution percentage that people will give to the marketplace at most is 8.5%. So yeah, if somebody is looking, and this is all a continuation, so it's really people who probably have already been moved into this over the last couple of years. This is a continuation to 2025.
Thank you. Appreciate that. Okay, if there are no other questions for Devlin and Sarah, then we are due for a break. We will take a 10-minute break, and well, maybe 11-minute. We'll return at 10:40 and see you on the other side. Thank you, everyone. Okay, I'd like to call everyone back to the meeting. We'll start shortly. And board members, it'll help me know you're back if you can turn your video on if possible. Thank you, Sandy. All right, calling everyone back to our September meeting of the Oregon Health Policy Board. We are going to, next on our agenda is public comment. And we do have some testimony today that we look forward to hearing. The Oregon Health Policy Board welcomes and deeply appreciates public testimony. It's actually one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We also will not interject or correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration of our work, and listen with that kind of careful attention, respect, and honor that you deserve. We want to acknowledge that whole time in our meetings to hear public comments is meant to provide a voice and perspective from that individual and is not representation of the Oregon Health Policy Board, its members, or the Oregon Health Authority. Each presenter will be given 2 minutes to share. And in the event that that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help us keep us on time, we'll start a slide with a 2-minute timer. Thank you. For each presenter, and we kindly ask that presenters conclude their presentation when the timer is complete. And please know that written and verbal public comments will be reviewed and discussed following each meeting by board chairs and staff to determine appropriate next steps. Board staff will communicate the next steps with each public commenter. So with that, I'm hoping that our public commenters are here today. You're welcome to share your video while you're presenting public comment. Although we do request that folks keep their videos off at the remainder of the meeting to help reduce bandwidth issues. But first up is Thomas Busse. Great, I see you. Welcome, Tom. And just so people know, Michael, and good morning, Michael Huntington will be next. Tom, welcome.
Good morning. My name is Tom Busse. For identification purposes, I'm the treasurer of the Multnomah County Libertarian Party and Libertarian Party nominee for Oregon Congressional District 1. I'm speaking this morning to complain about continued abuse of the flawed 430B prescription drug program by bad actors in the Portland area, specifically in partnership with the corrupt pharmaceutical giant Gilead Sciences. Specifically, Central City Concern and the Cascade AIDS Project, both of whom operate in-house pharmacies in their federally qualified health centers. Essentially, both organizations steal millions in taxpayer funds from the Oregon Health Plan by cheating the state of Medicaid rebates for expensive and unnecessary hepatitis C direct-acting antivirals. The Oregon Health Authority's recent report on healthcare costs singled out the 2015 decision for Oregon Medicaid to cover these drugs. Both the British Medical Journal and the highly respected Cochrane Collaborative have found no evidence for any clinical benefit for these expensive and toxic poisons, which are associated with a threefold increase in serious adverse events and very aggressive cancers. This was also the conclusion of the so-called evidence-based Pharmacy and Therapeutics Committee, but they decided not to follow the evidence and go into executive session in violation of the open meetings law to cover Gilead's products because Gilead threatened to use their lobbying influence in DC to revoke Oregon's Section 1115 waiver. The racket works like this. Gilead established a fake charitable HCV screening program called Focus through its foundation, shielding its spending from CMS open payments. They paid an OHSU doctor 20,000 years to establish an in-house pharmacy. Under the cover of research, he partnered with a testing lab that created a test that would deliberately create false positives. They then robo-prescribed 1,000 prescriptions to active injecting homeless drug users in the Portland area. 585 of them were lost to follow-up. No, they tossed the drugs in the toilet. This cost the Oregon Health Plan over $8 million, and it needs to be shut down. Thank you.
Thank you for your comments, Tom, and participation. Next, I'd like to hear from Michael Huntington. Michael, are you on the phone?
Yes. Can you hear me now?
Yes, we do hear you. Thank you.
Thank you for allowing me to speak, and thank you, all Oregon Health Policy Board members, for finding ways to provide health care for all Oregonians within our current set of rules and incentives. As you deal with the complexity, confusion, call waiting times, and churning of people in and out of eligibility, I want to remind you that there is hope. It's a hope that can energize you through what I assume is often fatiguing and frustrating work under our current system. I ask that you as individuals and a board pay close attention to the recommendations from the Oregon Universal Healthcare Task Force that was commissioned by Senate Bill 770. The task force will present its recommendations to the legislature at the end of this month. Number two, please review the 2019 Elway Institute poll that showed 75% of Oregonians favor universal health care that would be publicly funded and publicly managed. 62% indicated they would pay twice their current state taxes in order to be free of the constantly rising health insurance premiums, uncertainties, deductibles, out-of-pocket, dependency on healthcare access to your job, your zip code, your income, or your age, or your spouse. Number three, please support and originate bills that build the infrastructure that will be needed to support a true universal healthcare system. A good example is the Pharmaceutical Price Control Board that was authorized by this year's legislature. Again, thank you for the very difficult work that you are doing. To keep your hopes and spirits up, please envision the ultimate goal of a system that is simple, efficient, equitable, and free of perverse incentives. That is, publicly funded, publicly managed, universal, single-payer healthcare system. Thank you.
And thank you for participating today. Great. Well, that concludes public comment. Appreciate all those who participated. Next up will be Laurel Swirtle. So heads up, Laurel, you're coming up. So we welcome OHA staff with the Office of Health Policy to provide updates on the Bridge program and recent recommendations from the Bridge Program Task Force. Laurel, will you kick us off with introducing yourself and the team?
Yes, I would be honored to do so. Good morning, everyone. My name is Laurel Swerdlow. I use she and her pronouns. I am a policy analyst in the Office of Health Policy, and I serve as the project lead for the Bridge program. I'm joined today by my colleagues on the Bridge program team, and we are looking forward to giving you an update on what we've been doing over the past 6 months or so. Next slide. So first, we'd like to introduce ourselves. So I just did that. I'm going to hand it over to Nikki. Nikki, are you on? I know she was in another meeting, so it's possible she's coming in late. I think Tim is with us though.
Yes, hi. Good morning to the board. I'm Tim Sweeney. I know I've at least met and presented to some of you before. I'm in the Office of Health Policy on our coverage team and have mostly been our policy lead in developing the Bridge program, basic health programs that you're going to hear about. And then since Nikki's not here yet, I'll kick it to Katie.
Am I unmuted now? There we go. Hi, everyone. My name is Katie Waldo. I use she, her pronouns, and I am the new project manager for the Bridge program. So I just started in August. It's nice to meet you all.
And I just got word that Nikki is held up in a previous meeting, so hopefully she'll be able to join by the end and you all can meet her as well. Over the course of the next 45 minutes or so, I will just remind you all of the vision and timeline for the Bridge program. I'll talk a little bit about the task force that is working with OHA on development of this program. And then lastly, the work that we've been doing to solicit feedback. Next slide. So let's start with a reminder of the Bridge program vision and timeline. You can go to the next slide. So who would this program cover? As you know, when we start the post-PHE redetermination process, adults above 138% of the federal poverty level will start to lose their OHP coverage. This population that hovers just above Medicaid eligibility is often part of the churn population, folks who cycle on and off Medicaid due to fluctuations in income. Estimates of how many people just above Medicaid eligibility who are currently enrolled in OHP vary. The Oregon Health Insurance Survey, OHIS, suggests that around 45,000 people are currently covered by OHP in this income range. Forecast estimates have been in a similar ballpark, so we're estimating anywhere from 40 to 60,000 people are currently enrolled in OHP with incomes 138 to 200% FPL. When you take these two issues together, this issue of churn and this issue of the public health emergency unwinding, it becomes really clear that adults in this income category would really benefit from a new affordable coverage option. Next slide. So HB 4035 authorized the state to create a bridge program to provide affordable health insurance coverage and improve the continuity of coverage for this population. The bill calls out that the program should be administered by CCOs with little to no cost to enrollees and cover a robust set of benefits. It also articulates a vision in which adults eligible for the Bridge program could still choose between coverage by the Bridge and buying coverage on the marketplace using tax credits. Next slide. So after lengthy discussions with CMS in the first half of the year, they gave us guidance on a viable pathway to actualize this vision. In the immediate term, we need a temporary 1115 waiver to catch the people disenrolling from OHP due to income limits during redeterminations. This is what Dana was referencing earlier in the meeting. This is actually a requirement in HB 4035, and the 40% match that would be required for this is actually already baked into this biennium's budget. In this phase, folks who are disenrolling from OHP who are 138 to 200% FPL will essentially get to keep their CCO coverage while we work to operationalize the basic health program. Next, CMS advised that we submit what's called a 1331 Basic Health Program Blueprint. Section 1331 of the Affordable Care Act allows states to use federal funds to offer essential health benefits for people below 200% FPL who are above Medicaid income eligibility. So in Oregon, this is folks 138 to 200% FPL. I'll note that HB 4035 directs the board to approve this blueprint, and I'll talk more about that in a second. CMS will allow Oregon to operationalize the basic health program in two phases. First, people who were on OHP during the PHE who now have incomes 138 to 200% FPL will be transitioned into the BHP. Next, the BHP will open to people in this income category who are uninsured, as well as those folks in this income category who are covered on the marketplace. So by the end of phase 3, everyone in the state who is 138 to 200% FPL who wants subsidized healthcare would be covered by the basic health program. Then finally in phase 4, Oregon can consider whether or not it wants to pursue the final iteration that is outlined in HB 4035 of this bridge program, which would give consumers the choice between a basic health program and coverage on the marketplace. Some people refer to this phase as a phase that would enable optionality. This would require a state-based marketplace, and there are a lot of outstanding legal and operational challenges that would need to get worked out, which is why this option isn't immediately available. But this would be the final iteration of the bridge program if it's determined that it's desired. Next slide. So what is our timeline for doing all this? The Department of Health, oh, you can go back. Yeah, thank you. The Department of Health and Human Services officially extended the PHE by 90 days on July 15th. So the soonest that the PHE is set to expire is October 13th. And I know you all have been tracking this, but just to reiterate, states will be given 60 days advance notice prior to the end of the PHE unwinding. And because no such advance notice has been given, we can safely assume that the PHE will be once again extended. When the PHE does begin unwinding, as you know, Oregon will have 14 months to complete the redetermination process once the PHE expires. Next slide. So this is the timeline that we're working with right now, with, again, this one big caveat being sort of this shifting target of when the PHE will expire. At this time, because we can safely assume that the PHE will once again be extended, the timeline that you're looking at here would give us a PHE expiration date of January 11th, 2023. I want to note that there's additional skepticism that the PHE will even expire in January, but in an abundance of caution, we're outlining here an implementation timeline based on that January 2023 expiration date. So during the first 2 months of this redetermination process, we'll be working on reaching folks and giving them time to respond. This means that we would not start disenrolling anyone due to income until about March or even April. When we do start disenrolling folks is when phase 1 would kick in. And from the consumer side, as I said, they shouldn't notice any change in their coverage. They'll simply be able to stay in their CCO, keep the same provider network, and have the same coverage services. And that phase 1 should go on more or less for the duration of the 2023 calendar year. Also, at the beginning of the year, we'll submit our BHP blueprint and begin those negotiations with CMS. Our goal is for the BHE to be operational by 2024, at which point the folks who are currently covered by OHP in this income range would be enrolling in the BHP. Then for open enrollment of October 2024, that is when phase 3 would kick in which everyone in this income category seeking subsidized healthcare would enroll in the basic health program. Next slide. So there's a lot of work going on right now to develop this proposal for the basic health program, and the Bridge Healthcare Program Task Force is a big part of that. Next slide. The task force met once in April and then twice in May, but it really started to dig into the substance in June, which is when they received results from an initial feasibility analysis. And it's also when we had received guidance from CMS that the focus should be on building a basic health program. What you see here is a high-level outline of the roadmap that they've been following. There are sort of 3 main components that have been guiding this roadmap. The task force has been receiving ongoing actuarial analysis and related research to estimate both the revenue that we will receive from the federal government to implement this program, and then the estimated cost of actually implementing it. And this actuarial work is informing the main charge of the task force, which is to develop a plan design proposal. The question here really is, given the amount of money that we anticipate receiving from the feds to implement this program, what does the task force recommend with respect to enrollee costs, covered services, and provider reimbursement for the basic health program? Then lastly, the sort of third main part of this roadmap is related to questions around strategies to mitigate negative impacts on the marketplace. When the BHP is fully operationalized, as I've said, folks 138 to 200% FPL who are currently on the marketplace will be transitioning to the BHP. And so HB 4035 directs the task force to consider mitigation strategies that may be necessary to mitigate any impact that transition might have on folks above 200% who remain in the marketplace. So on September 1st, they submitted an interim report to the legislature, and then the fall is going to be spent returning to these topics following the results from a deeper actuarial analysis. The final report is going to be submitted sometime in November or December. And it's important for you all to be tracking that because 4035 directs that the final report inform the blueprint that you all will ultimately be approving or responsible to approve. I want to note that Stephanie Caballero is the OHB representative on this task force. She is a member of the board's Health Equity Committee, and she presented to you all back in June. Unfortunately, it was somewhat of a last-minute switch to make this update a more robust update, and so she wasn't able to join today, but I know she's really eager to report back to you all personally, probably at the November meeting is when I'm guessing would be best. And it just so happens that Kirsten's also a member of the task force as a labor representative. So she may also be able to speak to the task force member perspective if you all have questions about that at the end of this update. But I'd like to pivot now to offering some more detail on each of these topics. Next slide. So as I mentioned, the September report was heavily influenced by a feasibility analysis that was conducted back in June. This was not a full actuarial analysis. It was a very high level analysis to consider whether or not we should even be looking at a basic health program. And at a very high level, it indicated that the bridge program vision, as articulated by House Bill 4035, could pencil out. There were a lot of caveats, though, which is why we're pursuing a deeper actuarial analysis. The feasibility analysis only looked at 2 of the 3 populations that are going to be entering the basic health program. It considered folks who are currently uninsured in this income category, as well as folks who are in this income category and covered by the marketplace. But it wasn't able to include folks who are currently on OHP who would be transitioning to the BHP, which is obviously a key population for this program. It's also the population that's sort of most difficult to estimate, which again is part of why we're doing this deeper actuarial analysis. This analysis also used a benefit package that incorporated the essential health benefits and added in dental. But it did not use the OHP benefit package. Again, another reason that we're pursuing a deeper actuarial analysis. Next slide. So based on this feasibility analysis, the task force pulled together its interim report that was submitted on September 1st. And the report essentially documented the state's pivot to pursuing a basic health program based on the guidance that we've received from CMS. And it indicated, again, that based on the current feasibility analysis, the task force would recommend a plan design with no enrollee costs, the CCO service package, and capitation rates that would enable higher than OHP provider reimbursement. It further reinforce the bridge program vision of being administered through CCOs and having an implementation processes that align with OHP. Next slide. But again, that recommendation could really be subject to change based on further analyses. We conducted a benefit crosswalk over the past couple months that compared the EHB, the Essential Health Benefit Service Package, to the package of services that are covered by CCOs. We did a bit of a deeper dive into what we know about the OHP population that will be entering the BHP. And then lastly, we put out a carrier data call that will enable a micro simulation to assess the impact of transitioning folks from the marketplace to this basic health program. So all of these components are informing the final actuarial analysis that the task force will be receiving in October, which will ultimately inform its final report in November, December. Next slide. And should that final actuarial analysis indicate a need to reduce costs, these are the three main levers for doing so. Once we get additional analyses, to the extent that changes to the recommendations are needed, the task force could consider changes to covered services. There are caveats to that. There's potential for CCO operational issues. There's potentially some health equity implications of covering more services for BHP enrollees than are covered for OHP enrollees. The task force could consider adding in enrollee costs. This could be in the form of monthly premiums. It could be in the form of copays. Of course, both of those have possible implications. And lastly, it could consider alterations to payment rates. Of course, there's a point at which, decreases to PMPM rates become untenable for administration. So these are the three levers that the task force sort of has at its disposal when thinking about possible changes to plan design that could be needed from the results that they may see in the final actuarial analysis. Next slide. So as we're working with CMS and with the task force on developing this BHP blueprint, we've been making sure to be soliciting feedback along the way. And so I'm going to start now to outline the various avenues for public engagement that we've been pursuing, starting here with tribal engagement. You all know the importance of tribal engagement and the context under which we engage with the tribes, but for members of the public listening in, we wanted to make sure to offer full context for this. Federally recognized tribes are individual sovereign nations. The US government and the state of Oregon have unique legal relationships with American Indian tribal governments. These relationships are outlined in the Constitution, in numerous treaties and statutes, court decisions, and executive orders. So when we talk about tribal engagement, we're talking about engaging in government-to-government relationships with each tribe. Each tribe is a separate sovereign nation with powers to protect the health, safety, and welfare of their members and to govern their lands. In Oregon, there are 9 federally recognized tribes. In addition to the tribes, we have the Native American Rehabilitation Association, or NARA, which is the state's urban Indian health program. And so to ensure consistent engagement with all tribal leaders and NARA, OHA has a formal tribal consultation and urban Indian health program confer policy that guides our consultation process. Next slide. Per this policy, the process begins with formal notification to tribal leaders through what's called a Dear Tribal Leader Letter, or a DTLL. The DTLL is a critical component of this process. Once the tribes receive that letter, they have 30 days to decide if they choose to engage in further discussion and consultation on the issue at hand. If they request that consultation, this is a more formal meeting with elected tribal government officials or designees, and our agency director, Director Allen. If they want more information but don't believe a formal consult is necessary, they may request a presentation at a regular meeting, which are less formal and happen more frequently than consultations. Because we've been working to ensure really robust engagement with the tribes on all program components that may impact the tribes, they've become somewhat inundated with DTLLs. And so OHA is working to manage the timing of when those Dear Tribal Leader letters are released to be more mindful of their limited capacity. Next slide. For the Bridge program, Tribal Affairs has advised that we need 2 separate DTLLs. The first is the Bridge to the Bridge DTLL, which is an explanation of phase 1 of implementation, and I'll talk about that more in a second. The second is a broader DTLL that focuses on the full BHP proposal, including the marketplace mitigation strategies. Both DTLLs are with Tribal Affairs, waiting to be released to the tribes, and the Bridge to the Bridge DTLL is actually next in the queue to be released. Next slide. So as I said, there's the DTLL focusing on what we've been calling the Bridge to the Bridge, and we're conducting this tribal engagement, but we're additionally in the middle of our formal public comment period for the general public, which is required as part of the SUD 1115 amendment application process. As you know, as I've said, CMS offered this guidance that the best way to ensure sort of prompt review and approval of phase 1 of the path to the bridge, in which the state sort of temporarily expands OHP to go up to 200% during redetermination. The best way to do that would be by amending the state's freestanding SUD 1115 waiver. Again, the main purpose of this amendment is just to temporarily expand OHP to include folks 138 to 200% FPL for up to 14 months following the expiration of the PHE. And this will ensure that the BHP eligible population that loses OHP coverage during redetermination will actually get to stay on their CCO while we're getting the BHP up and running. There's an additional provision that we added to this amendment based on some guidance that we received from Tribal Affairs and from our fee-for-service team as we were drafting the DTLL. Oregon has a long-standing tradition of offering tribal members a choice between enrolling in a CCO and keeping fee-for-service coverage. And so in order to ensure that that tradition is continued through implementation of the BHP, we included a provision in which this demonstration will expire for everyone except tribal members once the BHP is implemented. That way, when the BHP is operational, tribal members will be able to choose between enrolling in a CCO and keeping the fee-for-service coverage that would be enabled through this amendment. Next slide. So this is our Bridge to the Bridge amendment process and timeline. As I've noted, we are in the midst of public comment. Public comment launched on August 1st. We've held 2 public hearings, and tomorrow is the end of the official public comment period, and we will begin integrating feedback into the application itself. We hope to be submitting this amendment sometime in October and aim to be beginning negotiations at that time. Next slide. So now let's pivot to talking about the carrier table. Given that we are working to mitigate any impacts that the basic health program may have on the marketplace, we wanted to make sure that we're engaging carriers to collaborate on these strategies. The purpose of the carrier table is to meet with health benefit carriers who offer plans on the individual marketplace to discuss the impact of creating a BHP on the individual market and to develop viable solutions for addressing those. These meetings are meetings that are being held by Director Allen and DCBS Director Stolfi. They will occur over the next couple months, and summaries of these meetings will be reported back to the task force as they occur. Next slide. So one of the main things that this carrier table will be focusing on is a possible revision to our 1332 state innovation waiver. Dana mentioned this earlier as well, and I want to offer a bit more context because it's really currently a main focus of our conversations with CMS, and again will be a main focus of our conversations with the carriers. Because marketplace enrollees will be transitioning to the BHP will reduce federal tax credits that are coming to Oregon, and that creates savings for the federal government at the expense of Oregon consumers. So we're working with CMS to amend Oregon's 1332 waiver to document those savings and then recoup them as pass-through funding that would enable a state subsidy program for those folks above 200% FPL who remain on the marketplace. Again, our goal there is, of course, to be mitigating the financial impact on marketplace enrollees 200% FPL and above, but we also want to make sure that this program allocates subsidies in an equitable manner and that implementation is as straightforward as possible. There are certain operational limitations that we need to be thinking about, mainly posed by the fact that we're still operating on that federally facilitated marketplace that we were discussing earlier, which is a key part of conversations both with CMS and with the carriers. Next slide. So in addition to a carrier table, excuse me, we're working to get a CCO table together, which will be obviously critical because CCOs will be the entities administering this program. The purpose of the CCO table is to meet with CCOs to get their preferences on BHP plan design and also to be identifying any operational issues that they anticipate during implementation and to be developing solutions for those. These are meetings that OHA will be hosting with CCOs and will hopefully occur during the weeks listed here, but then monthly thereafter. Our goal is for these conversations to be ongoing up until implementation and perhaps even past then. We're still working with the CCOs to get that timeline and roadmap solidified, so we'll be sure to report back to you all when that happens. And at these meetings, we've requested that the COO or a COO designee join these meetings to make sure that we're really able to dig into these operational questions. So that is it from me. And it looks like, wow, I was able to get through that more quickly than anticipated. So we have plenty of time for questions.
Great. Do any board members have questions? Bill. You're muted, Bill.
All right. Laurel, thanks very much for a really good presentation. This is a very important program. Understand that it's very complex to have it fit with all the existing state programs and the timing. One thing that you touched on, but I may have missed how it was resolved, was the issue about benefit design, and that the actuarial analysis actually indicated that benefits could be expanded beyond what's currently available in, for example, in Oregon Health Plan. But I'm not sure if it's been resolved what the there's also reasons to have a uniform benefits. So when people move between programs, that they aren't gaining, losing benefits, and there's not kind of some selection issues created by those different benefit packages. Has the group landed on a position around benefit design, or is that still up for discussion? Could you say a little more about that?
Yes, thank you for that question, because it's offering an opportunity for me to clarify. So the original feasibility analysis looked at a package of services that included the essential health benefit package and added in dental. we conducted a benefit crosswalk to see what else is covered by OHP that is not included in that benefit package that was analyzed in the feasibility analysis. What we came to is essentially the EHB package and the OHP covered services package, the covered services provided by CCOs, are essentially identical. There are three main differences. OHP covers dental, it covers non-emergent medical care, and it covers bariatric surgery. Those are the three main sort of differences between the essential health benefit package that was analyzed in the feasibility analysis and the CCO service package. The task force has been really clear that its goal is to have a program that includes the whole CCO covered service package. So the goal is to be, again, to your point, having a program that implements the same covered services that are covered for OHP enrollees for the BHP population. You know, all of this is subject again to this final actuarial analysis, but big picture, it's been pretty clear from the task force that they really are wanting a program that includes the full OHP benefit. To your point, not more than that, both for the equitable reasons, but also for the operational reasons. So again, it's the OHP service package that's the goal here. Did that help answer your question?
Yes, great. Thanks very much for the clarification. That's helpful.
Yeah, good.
Any other questions from board members? Okay, well, I just want to thank Laurel and the team for coming before us today. And this will be a topic for our board to continue to hear updates on and wrestle with. And I just, for some kind of context, I don't know if folks remember when this kicked off, it was kind of like a let's do a stretch here, and not just lose coverage for this population that is currently on OHP, who will be redetermined, but also to not lose sight of kind of the equity gains that happened, that we kind of fell into, but then still let's hold tight to them because of who this population is and the challenges that the churn population has always had for those individuals and for the program, and that's broad implications on our state and its health. And so I think short term, I think about this program as how do we solidify those gains and continue that on. And then long term, I really see this program as, you know, here at our board, on this health policy board, we sometimes kind of dip into the weeds when we think about, like, you know, what's the call wait time for the one system right now. But we also need to keep a big picture. And I think this is one of those programs where we have the opportunity to continue marching forward toward a health system in Oregon that is focused on health, not just providing services. And I think this is an opportunity to take a step forward in that direction with tremendous gains, not just in a way that is affordable to the state and maximizing federal assistance, but in a way that will have real impacts on many Oregonians and improvements. So appreciate all those working towards something new and something different and something better. So thank you for your work. And with, Sandy.
Yeah, I just have a quick question. So with the 138 to 200 FPL, you know, that was initiated by ACA. So are you going back to 100% FPL as what was prior to 2013, 2014?
That's That's a great question. So the OHP eligibility will not be changing as a result of implementation of this program. So there's still going to be the 138% cutoff for adults in OHP. What's happening here is simply creating a new eligibility category for a new program that is this basic health program.
So what about children under 5 and 6, and then I think it was 5 or 6, and then also how does it affect, so adults over 18, this will affect, and then also you stated that I guess I have to go back and review the ACA again and how it's going to affect everybody. So I mean, I understand the bridge program, but you're throwing a lot of stuff into a mix with the marketplace exchange, and then you said this will affect 45,000 people. You've got the 1.4 million people that are currently enrolled in Medicaid, and the public health crisis that we may go back into one. So right now we've got until January 11th to really look at what CMS is going to do. And I guess there's a lot going on that is kind of scary. So I remember a lot of, I've been in this, working with this type of stuff since 1997. So I guess just the changes and effects. I know that you've got to keep it out under a certain percentage, but or even look at CMS, but and the 1115 waiver on some of these, how they affect the underserved population. So thank you.
Thank you. I really appreciate the comment and the question. I think the one thing I'll want to note just is that kids will not be part of this BHP. The BHP population is the 19 to 65 folks. So just wanted to make sure that that piece was clear. But also I really appreciate your comment, just that there's a lot of moving pieces here, and that it definitely complicates the task at hand. And also I think, makes it more urgent, because as Kirsten said, we're definitely at a crossroads here. We have an opportunity for a turning point to make sure that we're able to keep coverage for these folks. So thank you.
Great, thank you. Okay, we will move on to our closing comments and then adjourn the meeting. But definitely part of our closing comments is just recognizing that this is Jeremy Vanda Hayes' final OHPB meeting. And we'd really like to take a moment to wish him well. I know this happened at last month's meeting too, and some members did get to share some of their thoughts, but I know at least some of us were not here for that, and would really welcome the opportunity to share some words about Jeremy. So I'd love to open up the floor to my fellow board members, ask if you have any comments to share, Mr. Vanda Hayes.
Sure, I'll start. I've worked with Jeremy, when he was in the governor's office, and then also through the Oregon Health Authority, and going through a lot of these changes. So we will miss you. You've been very, just going through a lot of the operations part of the Oregon Health Authority, and even just working with the governor's office, and she's going to leave us this year. But I just want to say that I appreciate all you have done during this time. We're going to miss you, and I'm a little sad. So thank you so much.
Thank you, Sandy.
And
I'll go next. I echo Sandy's comments. I think you've been such an incredible attribute to the state and to OHA, Jeremy. And I really appreciate your capacity to address complexity with grace. recognizing is when systems fail and people that make up systems make mistakes, and how you move through that, or how I've learned how you do that. We've been really fortunate to have you supporting this board in our work. And I personally have learned a lot from you. And I wish you the very best in what's next for you. Yeah, thank you so much.
Thanks, Brenda.
I'll go to Jeremy. Thank you for spending so much time with me, getting me up to speed on healthcare policy. We've spent many a phone call going through just sort of the system and nuances that impact costs, going all the way back to the target setting committee. And I just want to say I really appreciate that time that you invested in departing your knowledge on me. I really appreciate it. So, and we'll miss you as part of the work that this board does. So.
Thanks, Jessica.
Can you all hear me okay?
We hear you, Ebony.
And, Jeremy, I spoke last time, but again, just want to reiterate just, your commitment to living up the value of, really being a equitable and consumer driven system. And, you have a lot of expertise and knowledge in the vast work of OHA. And, you were very incremental in welcoming me. And I remember thinking like, oh my gosh, there's so much that you have to know about and learn and do, but with your knowledge and just support and how you kind of helped welcome me in, I'm not going to forget that. And, it will be, a loss to us. And, I'm committed to continuing to carry out your legacy and making you proud. So just thank you for your work.
Thanks so much, Ebony. This is very uncomfortable for me, so I'm just sitting here patiently.
Maybe I'll add to your discomfort, Jeremy. Hopefully not. I did have a chance to speak briefly last time, but I wanted to also express my appreciation for all that you've done for Oregon Health Authority and support for the board. The terms public service get bandied about a lot. And I think one of the things I'm most impressed by, have always been impressed by in Oregon, is the number of and the quality of people who work in the public sector, particularly in healthcare. And Jeremy, you're a personification of the best of Oregon's public service. Both the expertise that you bring, your understanding of health policy, the healthcare ecosystem, health insurance ecosystem is unmatched. Your awareness and sensitivity to political issues, but also your core personal values that come through in the work that you do, I think is that package is what really represents great public service. And I greatly appreciate all that you've done for the board and for the Oregon Health Authority. But I think you should feel proud that you've had a positive impact on the health of all Oregonians. It's not just you yourself, but you've done it through the team that you've built at the Oregon Health Authority and the people you've worked with, and that's a tribute as well. I hope that you have a great next stage in your career. Hope you can find a way to stay involved in public policy and broader issues in Oregon, and look forward to staying in touch and working with you in your new role. Again, congratulations and thank you for all you've done for Oregon.
Thanks. Thank you so much, Bill.
You're here to that. I really just agree with all of what everyone said there. And I'll just add that one of the things that I really appreciated about working with you, Jeremy, is not only your like kind of internal compass of like, hey, let's striving to do better, we need to do better, but also this practicality and methodical approach to implementing that. Like, I just feel like you're kind of like step by step we can do better and we'll reach that new destination. But let's break that down into, and so we can actually get there. And I think that you have a real talent at kind of seeing that faraway destination, but then navigating what's in front to with that in mind. And so really appreciated all your vision, your responsiveness, your humor, and you kind of have an amazing ability to never seem flustered too. And I don't know if that's, maybe we didn't try hard enough, but
Definitely does not feel that way to me, but
but thank you for all your service in the state of Oregon, and yeah, wish you the best of luck.
thank you so much. Thank you all for the really kind words. It means a lot to me. It's not a comfortable thing for me to sit through, and I really appreciate it. It's as I mentioned last month, you know, it's a real bittersweet move. I'm really excited for the next move and be able to learn new issues and see where that goes. And it's also bittersweet. It's, you know, I just think that been so fortunate to have such an incredible team within HPA. Just amazed at the work that the team does every day, and the amount of, you know, crazy ideas I've thrown at them, and somehow they keep coming to work and working really hard. And I think it's just represents folks' you know, true values and just really wanting to create a better health system for the state. I just want to say thank you to all of you for your commitment. I mean, health reform and healthcare is not for the sort of weary, and it's complicated. And I know we're constantly trying to strike that balance of you know, where the board should weigh in and how the board should weigh in, and finding the right level of the weeds. And I recognize that all of you have, you know, tons of other commitments and invest a ton of time and energy. For folks who don't know, I mean, I think everybody knows this, but yeah, when I came into OHA in 2010, I was like the 5th official OHA employee as we were sort of starting that transition of moving things out of DHS and bringing the other agencies. And my first job was an outreach job, which was basically to try to be the board's sort of liaison out to the community to explain what is this new agency and what are we going to do. And so I feel like I've been working with this board and variety of members for a long time. And I think we've gone through a lot of iterations of trying to figure out exactly where the right space is. But I think it's a really stellar group of folks. And I think when you've got a new governor coming in, I think the board's in a good spot to be able to explain what you've all been working on and the priority issues and how we're trying to strive to get everybody covered and make things more affordable and make the system more equitable. So we really encourage you to embrace the work that's already done and tell that story, because I think we've got a lot of really foundational pieces in place that are going to really help with our next wave of health reform in the state. And I would just encourage everybody to keep leaning in on that. But thank you all for the really kind words. Like I said, I kind of have the easy part often of just coming and doing a presentation, and there's a team that is working nonstop to really do the real work, and I get the benefit of just sort of showing that off sometimes. But I'm going to miss you all. I'm excited that I'm sure I'll stay in touch in the new role. But wish you all the best of luck. And again, thank you so much for the kind words. It's been an honor.
Thank you, Jeremy. And we look forward to seeing your continued service to the good people of Oregon, just in a different role. Thank you so much. Okay, well, our next OHPB meeting will be Monday, October 3rd, a very rare and unusual occurrence. We will not be meeting on Tuesday and Monday. And it's occurring instead of the first Tuesday because of conflict with Jewish holiday that is observed starting October 4th. So we look forward to seeing you all on October 3rd. And thank you, everyone. Bye-bye.